Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral fully occluding earwax. Now, they do attend the clinic every year or so to have their ears de-waxed, so they are a chronic earwax sufferer. However, on this occasion, they described their symptoms to be slightly different to the norm. They just felt a lot of pressure in the ear, which earwax can cause. It can lead to oral fullness, but typically in the past, the patients experienced just reduced hearing and a bit of discomfort, but this time they just felt a pressure in their ears, and they weren't even sure that they had earwax upon attending, but given they come every year, they assumed it was just the wax. So once I've removed the earwax from both sides, and it was quite a lot actually, I revealed that the patient has got otitis media with effusions, which basically means they've got a middle ear infection with fluid buildup. So the term effusion means fluid buildup. And this is some dry wax here that's lodged in the inferior recess. I'm just using the fine end suction probe to remove that. The wax is really dark, it's dry, it's crusted. Now, you can see there's a piece of wax at the roof of the ear canal. And sometimes, although it's like in the wrong location, that's what a cholesteatoma can sometimes just appear like. But the cholesteatoma normally is in the posterior superior quadrant where the eardrum's retracted. Now, this patient has got a retraction in that region. You will see it in a moment. So that dried wax plug is on the more anterior superior canal wall. So sort of northwest, it's on the northeast. So, but nonetheless, I just want to remove that just to make sure there's nothing underlying, which there isn't. So there is still a bit of dry skin right on the roof, but that's away from the eardrum. I'm just going to leave that because that's part of a sensitive part of the ear. A little bit on the hammer bone, I'm just going to hover over it, comes away brilliant. Again, I don't want to make contact with the hammer bone. Now, in both ears, there's evidence of a really, really small healed pinhole perforation. Now, if you look closely at the eardrum itself, on the bottom right, they might have just come out of view there at 4 o'clock, there's a little red mark there, it's like a puncture mark, and you can see the fluid, the yellow appearance at the floor of the eardrum. So just where that wax is, I'm going to try, you can see that wax is hidden away in the anterior recess, but I'm going to remove that, because again I just want to make sure there's nothing else going on behind here. But just below the suction probe you can see a little red mark, and I suspect the patient suffered from a little pinhole perforation, which has since healed, and it has healed because I did do a pressure test to confirm whether that eardrum is mobile or not. When you've got a hole in the eardrum, the pressure either side of the eardrum is equal, and you get what we call a flat timp. So for all the audiologists watching there, that will make sense. So the patient has, and if you've got a perforation, the ear canal volume is higher than normal, which in this case it wasn't. So this patient did have a flat timp, a type B tympanogram, but the ear canal volume was normal, which suggests that there's no hole in the eardrum. Again, just inferiorly, you can just see like a bit of a yellowy appearance behind the eardrum. That's the effusion, that's the fluid buildup, and I suspect that fluid buildup a week or so ago, that's when the patient reported some quite more intense pain, had punctured through the eardrum. There's too much fluid accumulation behind the eardrum, so it burst the eardrum, but the patient just developed a pinhole perforation. If you think about it like a water balloon, it's only so much water that balloon can contain and hold before it bursts. And similarly, there's only so much fluid buildup behind the eardrum that the eardrum can contain before the eardrum gets ruptured. And the reason why the patient has got fluid buildup is that they suffer from quite severe hay fever, and that hay fever causes nasal congestion. That nasal congestion blocks the eustachian tube where it connects to the back of the nose. The eustachian tube is the pressure equalizing tube and the drain pipe that connects the back of the nose, the nasopharynx, to the middle ear, which is a cavity behind the eardrum. So it allows for the equalization of air pressure, because we want the air pressure to be equal either side of the eardrum, and it also allows fluid accumulation behind the eardrum to drain out through the eustachian tube. If that's blocked, there's no air that can enter behind the eardrum, so all the remaining air in the middle ear cavity gets absorbed by all the cells contained in the middle ear. The absorbing of air by the cells in the middle ear then leads to the excretion of fluid out of the cells into the middle ear, and that fluid would typically drain down the eustachian tube through the back of the nose. But because that eustachian tube is blocked at the back of the nose, the fluid collects. It can then get infected and become very viscous, hence the name glue ear. So if you've heard of glue ear, it means infected fluid, very viscous, sticky type of fluid that's accumulated behind the eardrum. So I've cleared the wax. Similarly to this ear, you'll see it more anteriorly, so at 9 o'clock. It's a bit more visible here. I think, again, there's been a puncture of the eardrum through excessive fluid buildup, and there was a bit of granulation tissue there, and there's also possibly a bit of dried up middle ear effusion that was kind of almost dripping out of that. And you'll get a better view in a moment. You'll see that. I'm going to actually remove it. Both eardrums are retracted superiorly. Again, there's a bit of dead skin at the roof of the eardrum. I'm going to remove that. I'm just mopping up some of this wax off the eardrum first and the inferior recess. So you can see that the eardrums are sucked in, especially just below the suction probe there. That's the attic region. So that's the pars flaccida. It's the thinnest part of the eardrum, and because it's the thinnest part, it's more susceptible to pressure change. It can, when there's no air behind the eardrum in the middle ear, it creates a vacuum effect. Probably should have explained that earlier. So when the eustachian tube is blocked, there's no air behind the eardrum, so the eardrum gets sucked inwards. It creates a vacuum effect. Now, you just saw that closer. There's a little possible drop. It could just be some granulation tissue discharge, but it could also be some middle ear effusion that comes. If you think about your squeezy ketchup bottles, when you squeeze through and you get drips coming through the tip of the plastic that's cut in quarters. It's a little slice of the piece of plastic at the top of the ketchup bottle, from 12 o'clock to 6 o'clock and 3 o'clock to 9 o'clock. And when you squeeze hard, that thick ketchup goes through the tip. Similarly here, there's a bit of fusion, I reckon. And both pinhole perfs are now healed, but the fluid's still there. You see just how dark that earwax is. So the patient has been recommended some nasal decongestants for their hay fever, also the Otovent nasal balloon, and I've written to their doctor, because if it doesn't resolve after these treatments, they may need some antibiotics and onwards referral to ENT. Take care, bye.